Hello and welcome to Health on the Line, where I'm delighted to have a special guest that joined me in person last week from the other side of the pond, Al Mulley of the Dartmouth Institute's Global Healthcare Delivery Science Programme. The programme, that's the Dartmouth Institute's programme, is dedicated to forging partnerships around the world to build the capabilities essential to achieving sustainable healthcare economies. We've had a fascinating conversation about issues like variation, clinical decision-making, how the NHS can implement the neighbourhood health ambitions contained in the 10-year plan. But before we get into that, I'm joined by someone a little closer to home, our very own Heather Moorhead, Director of the Northern Ireland Confederation for Health and Social Care, or NICON as it's known. I've talked to Heather fresh from a wonderful NICON conference that I attended earlier this week in Belfast. Heather, welcome to Health on the Line.
Thank you very much, Matthew. I'm very glad to be on. I often listen, so it's nice to be with you today directly myself.
Yeah, it's a thrill having you on. Now, Heather, how I left your conference after, about halfway through, 600 people, a real buzz. How did it go?
Yes, it was amazing. We'd 800 people there over the 2 days. With the whole system in the room, and everybody says best yet. So that's deeply encouraging. And I think that was because we have one plan and everybody going the same direction. So there's a real sense of energy.
Yeah, no, I felt that. I mean, NICON is the second biggest conference we organise behind Confed Expo. It's a fantastic gathering. Now, exactly as you said, what I found was a real sense of shared purpose, and it's all around this reset plan that the Northern Irish government published, I think in July. So just what are the kind of key features of that plan, Heather?
I think the reset plan, Matthew, really follows a lot of the work that you're doing in the 10-year plan. So in Northern Ireland, we've already got Encompass in all our trusts. So that's health and social care because we've an integrated system. So that gives us a massive platform to really build out our digital work. So that's one thing that's massively exciting and everybody's really committed to. One of the other things is that we've just begun our work on neighbourhood, and we launched at conference our new primary care network, which is massively, it's taken us a good long time to get that to happen. And largely speaking, I love that because you prompted me to say, where's the primary care network in Northern Ireland? And we launched it. The other piece of work that we launched is we've got a people to partners report, and we did that across the whole of government so that health was working with all our government departments of really taking an assets-based approach, of really getting deep into our communities and do with approach. So those are some of the key themes. Well, some of the other things that we were looking at was our winter plan on our flow, and really thinking about redesigning our design of our hospital services. So those are the key things.
So one of the things that really struck me, Heather, was that it didn't feel like there was the same tension that I often find in England between kind of recovery, things like getting the waiting list down, getting the money under control, and reform. It's all very difficult, but it all felt like it was kind of part of one project. And there has been a little bit of progress, hasn't there, on waiting lists in Northern Ireland, albeit from a really unacceptable baseline.
Yes, massively unacceptable. Has been a priority for our programme of government to work on waiting lists, but there's been a concerted effort and we've made really good progress, which they were able to announce at conference, and that has been hugely welcomed by the whole of the system. And I think the other thing that has been a sort of a cloud hanging over everybody is we began the year with a £600 million deficit. And our system has saved almost half of that. I think nearly twice the amount of savings that the NHS was expected to make. So, and we're leaving conference with the executive announcing today that they've found the money for our pay increase. There's been a big concern that we'd end up with industrial action over the winter. And that was the big ask from our members, that we've made a lot of progress right across the system, that would be stalled by going into the winter with industrial action.
And then the other thing, I guess the thing that I found most exciting, Heather, about coming to Nikon was that, when you and I started working together a few years ago, it was really hard for you to get a foot in the door. of decision making in Northern Ireland around health, and that's gradually started to change. And you and I, we agreed, didn't we? 2 or 3 years ago, that what we really wanted to do was to get away from a kind of master and servant way of working in Northern Ireland to one in which the people running the health service saw the chief executives of the health and care systems as partners in change. They were a single team working together with mutual respect, all taking responsibility for their own organisations, but also for change across the whole of Northern Ireland. And that felt like a pipe dream, but it's really happening, isn't it? NICON is really central to the conversation. You've got all of the trusts now working together, systems working together as a committee in common. And you've got Mike Farrar, one of my predecessors as Confed Chief Executive, not as the kind of boss of the system, but really as the kind of convener of that group, all working together. It really feels like a dynamic way of working, Heather.
I think that's absolutely right. And these sort of things seem to arrive in public, but that was on the back of a lot of work. And the reason that work happened was that Mike Farrar came during COVID and did some work for Nikon with our chief executives as a development opportunity. So he was meeting with them once a quarter, helping them look up and out, because that's a big deal, Matthew. In Northern Ireland, we're small and we're a bubble. So our colleagues don't get time to really have their heads up and out. So we did that once a quarter. So they're looking to see what was happening in the rest of the world, what was happening in other types of businesses, but also building their relationships with each other and committing to each other. So it was in that began to nudge, and slowly our chief execs were very much able to report at conference that they really were committing to be collaborative across. We've got 6 provider trusts, and you could see and feel the game change of that. And then obviously, because Mike had been working with them, he knows them well, and he's come in as very much a facilitative leader. And that's really changing the culture. Northern Ireland's very siloed because we've a different model of government. Each different political party has a different ministry, and they tend to be very siloed. But Mike has really worked with not just his colleagues in health, but right across government. So there's a big theme of health and economy today. And that, again, an innovation and all of those things about how the language that Mike uses is that health is a horizontal budget. And he's saying to other government departments, we can't continue to take money away from your budget. Can you work with us? And he's been really successful in doing that. So we had our executive office with us, we had the Department of Economy with us. So it was a real whole of government approach. And you could see and feel that tangible difference. And that's why I think my colleagues are really embracing that. We'd Marmot with us. I should have said that earlier, because that was a real fantastic place to begin the whole conference, really looking at health inequalities. So there was a real shift in just a shift in mindset about everybody really beginning to think, well, what makes a difference in health? We can't keep going the way we're going, so that we really have a sense of making a shift.
Yeah, and Heather, there were so many positive things. There were a lot of clinicians. I went to a fantastic session about performance variation. A lot of members of the community at the session I went to about the public as partners, even colleagues from south of the border coming and talking about kind of how we can strengthen collaboration and understanding across Ireland. Well, I hope, listeners, that these notions of kind of mission-driven health policy in Northern Ireland, of collegiate working, have whetted your appetite, because next edition, you will be hearing my interview on the stage at Nikon that I recorded with Mike Farrar. Heather, thanks so much for joining me for this conversation.
Thank you, Matthew.
Now, returning to this episode, I was fortunate enough recently to catch up with Al Mulley at the NHS Confederation office in Westminster. I first came across Al's work having listened to his wonderful podcast series, The Choice, Securing the NHS for the Next 75 Years. And our mutual friend, Paul Corrigan, then put us in touch. I was particularly keen to talk to Al about how the model of care in neighbourhood health needs to be different. Before his appointment at Dartmouth, Al was at Harvard and Massachusetts General Hospital, where he served as Chief of General Medicine for nearly 3 decades. But he was also a visiting fellow for the King's Fund, where he worked with the fund on how to transform the delivery of health services through innovations that produce better value for patients. And in that, he looked at evidence from the UK and the US. It was a wonderful conversation. So enjoy.
So, Al, just let's start by you telling us a bit about yourself, your background, your work as a clinician.
I'm happy to, Matthew. Early on at university at Dartmouth, I became very interested in market failure. I read Garrett Hardin's Tragedy of the Commons, and I could see relevance to healthcare all over the metaphor, which, as you probably know, is sheep or cattle owned by multiple owners grazing freely on the common pool, and what happens under those circumstances. So I chose to go to medical school, to study policy and economics while in medical school, so I could learn more about that and make a difference. On the personal side, the reason I was already an admirer of the NHS is I grew up in the forest community in Leland, starting with parents who had very little education, immigrating from Newfoundland and Poland. I had 17 cousins, 14 aunts and uncles. We had very little access to healthcare unless we were ill enough to be across the river to the MGH, which is just a few miles, to be an A&E and admitted to an ITU.
Right. So you've been engaged with British colleagues for a long time, working to improve and sustain the NHS. How did you get involved in working with the NHS?
Well, as I said, I always admired the NHS from a very early age. Right after we passed Medicare and Medicaid, I recognized that they were pale in comparison to what you did in 1948. And what I learned at the Kennedy School, studying policy and economics while in medical school, gave me a focus on the quality of decision making. I learned a lot from economists about economic decision theory, game theory. That had me thinking about we can never judge the quality of a decision made in the face of uncertainty by its outcome. It was all about how carefully you thought about the options and the outcomes from different choices that might be made, the probabilities of those options, and most importantly, don't stop there because your work's only half done. You have to try and quantify the outcomes in the lives of people who experience the consequences. So from the very beginning of my clinical career, I wanted to be a generalist, spanning the breadth of medicine from primary care to ITU care. I did that, and in the intensive care unit, I made the distinction between unwarranted and warranted variation in the early 1980s. The year after I made that distinction and reported it to a presidential commission, Jack Wenberg published a paper replicating the work that he had done defining practice variation in New England, the Midlands of England, and Norway. I found that amazing because Clem McPherson was the first author, and Clem was from Oxford and at London School of Hygiene and Tropical Medicine at the time. And he developed the standard coefficient of variation, which was able to demonstrate that variation in elective surgeries was condition specific and essentially the same in these different countries, despite the fact that they had enormously different ways of organizing their health, the funding and provision of healthcare. So that's how I got started. Right from the time I went up and introduced warranted variation to Jack Wenberg, we started taking a deep dive into the complexity of clinical decisions, and Clem was part of that.
So let's get into some of these ideas, Al. So let's start with this kind of notion of variation. So we talk quite a lot in the NHS about variation, but we tend to be talking about variation in performance, whereas I think your focus is more on variation in activity. That the proportion of people who are treated, which we actually discuss much less. Is that in your work with the NHS, this question of variations in the number of people who are treated, the way they're treated, is that something that you've found that people in the NHS are interested in wanting to talk about?
Absolutely. When you do refer to it in the US as early as my introduction to working here in the mid-'80s, you referred to it as the postcode lottery, with seriously negative connotations, implying that resources aren't sufficient in one area, they are in another, and therefore there must be rationing going on. And nothing increases demand for services than suspicion that things are being rationed.
Right.
That's your problem. That's the problem.
Because sorry to interrupt, but in the States, when I've looked at this literature a bit, I've kind of assumed that these variations in the level of treatment reflect a market system where doctors are incentivized to treat people.
Yes, but it's much more than that.
Right.
It's there's no linkage between the clinical decisions made at the front lines, even though every clinical choice is a spending choice, and the decisions made by people commissioning services in for future use for a population of people, or for those making capital investments or doing workforce planning. There's no linkage between the decisions made and the capacity that is being built. Most exciting aspect of the work that I started doing in 2016 with my partner, also now in the faculty at Dartmouth, is that when we worked with frontline people and introduced them to the way we were thinking about decision quality as producing the critical intelligence that commissioners have never had in order to invest in ways that don't spur more use of services that aren't necessarily the ones that are needed and wanted.
So you spoke a few minutes ago about rationing. You would have thought that in as much as an element of kind of over-treatment might reflect the incentives in a market system where people are paid for activity, there wouldn't be such a problem in the NHS. But you find in the NHS similar kinds of variations in the level of treatment, even though we have got a whole set of guidelines and institutions and NICE and all sorts of other things which are there to try to reduce those kinds of unwarranted variations.
Yes. So just a little bit of the history of variation, both of our countries. Jack discovered it in the 1970s in New England. I told you about the international paper demonstrating that it was procedure specific, not terribly affected by the form in which services were funded and provided in those three countries, vastly different. In 2001, 5 years after the first Dartmouth Atlas of Healthcare, looking at variation across 1,300,000 regions, carefully defined, with careful measurements of the administrative data, vary dramatically for individual procedures, but also for hospitalization and per capita costs of care. And in 1996, it was clear that we were spending 3 times as much per capita on people living in Miami as on people living in Minneapolis. Now, then the question becomes, what are we getting? Are we getting value for money? The answer in 2001 was no. A very careful study published to much acclaim in the United States showed that the people in Miami were less satisfied with their care. Their outcomes were no better and perhaps worse. So there was an awful lot of activity going on that represented waste and potential harm to patients. That paper was discussed in 2002, I think, here by Jack and my colleague Elliot Fisher. And that really lit a fire under people thinking about variation during the implementation of the early 2000s NHS plan. Shared decision-making was recognized then. We had put it on the map in 1986, 1987, 1988. It was embraced here by people at the King's Fund, by people at Oxford who knew Clint and his partner Anne Pearson. They did something very similar with videos of patients so that prospective patients could get a sense of how they'd feel about different outcomes. So it was very much recognized as a source of learning. there isn't anything we learn from but variation. Sometimes we can control it in randomized trials. Sometimes we observe it. So there's a long history of this argument. And there was a bit of a breakthrough when I was commissioned by the King's Fund to join up practice variation, shared decision making, engaging patients in understanding what they think they need and want and why.
Yeah, because this is what I wanted to get to. Is there's not an intuitive link for me between the notion of variation and the notion of kind of decision points and the importance of decision points. So what is it that links these two ideas? We don't want needless variation because it implies that some people are being treated who don't need to be, and some people are not being treated who do need to be. But what is the relationship between that and what's at the heart of the podcast, really, which is focusing on the point of decision between the clinician and the patient?
So you can't judge the quality of a decision made based on uncertainty only by the care with which one thinks about what the options are and the conversations that lead to the choice, involving very much the expertise of the clinician, of course, but also the expertise of the patient about what matters to them at that moment in time in the context in which they're living their life. And what we've referred to as patient preferences. And the breakthrough I was about to describe is when I was commissioned to join up shared decision-making and commissioning. It gave me the opportunity to think and bring in some colleagues from Dartmouth to help me think in new ways and articulate that unless there were high-quality decisions being made, and measurably high-quality decisions, there was no feedback loop to system leaders who were doing the commissioning and investing in capacity and investing in workforce. And that feedback loop generates the critical intelligence that is needed to know where to invest and where to disinvest.
It's fascinating.
So there's the warranted. I'll tell you a quick story. The distinction came from a moment when I was walking back to my research office where I was studying indications, interventions, and outcomes of intensive care. I'd just come from a family meeting, and let's call the patient Mrs. Jones. She had been intubated in A&E nasotracheally. She wasn't getting very much better with the ventilatory support. So a decision had to be made about whether or not to do a simple operation and continue to support a tracheotomy, or to remove the tube and do everything we could to support her without that. And if she couldn't improve, she would die. That was a common family meeting in intensive treatment units in this country and in my country everywhere. And I was coming back proud of my trainees, including the medical students, for the empathy that they expressed. I felt good about the decision made by Mrs. Jones, who was awake and alert with her family present. And I was wondering how many cases like her I had in my database in order to narrow the confidence intervals around the probability of her having survived if we did the tracheotomy and persisted with the ventilatory support. And I had an epiphany. It really didn't matter. Probability might have been 1 in 50, 1 in 25, 1 in 10, but it was so low that the decision wasn't sensitive to the probability. It was dominated by how Mrs. Jones and her family felt about where, when, and how she was going to die. And Mr. Smith and his family across the corridor might feel very differently about where, when, and how he was going to die. I've been commissioned to work on intensive care decision-making for an ethics committee that Jameek Carter had put together. And I used that story to make the distinction between warranted and unwarranted regression. So there's lots of variation in how patients feel about exactly the same outcome. But there's lots of variation in how patients feel about exactly the same risk. And there's lots of variation in how patients feel about making some kind of quality of life sacrifice now in order for a better future.
So what I want to do is to explore what the barriers are to this, as it were, investment of time and energy in the decision point, in order that from that we can derive the information that we need that commissioners need in order to understand how best to commission the services that we want. So I guess one would be, an obvious one would be, we don't give clinicians the time, maybe we don't even give them the encouragement to create the space for those kinds of kind of conversations that in a sense, and I've heard GPs in particular say this, a patient comes in, you don't have that much time with them, they kind of want a diagnosis and they want something to take out with the surgery with them. They want to take a prescription, they want to take an outpatient's appointment out of that process. And it becomes quite kind of transactional. And with it built in is the assumption that a successful interaction is one that leads to some further medical intervention.
Yeah, no, that's exactly right. That's exactly right. After, between the work that I described began with Vanguard's NCPs and PACs. We learned a lot co-developing with Six Sigma across the country. We then reiterated that in the poorest communities of East London, and then in the Black Country in East of England. And after 7 years, we dared in a Black Country meeting in Wolverhampton, an away day of the chief nursing officers and chief medical officers, to put to them the galvanizing question: how do we avoid the financial waste of the system, the personal harm to patients, and the moral injury to ourselves, the health professionals, when we routinely substitute medical interventions for needed emotional or social support? And when you say that to a group of clinicians, they all nod no. It's not uncommon for, picking up on what you said, it's not uncommon to write a prescription for an antidepressant because your waiting room is full, you're behind, you're trying to do your very best with the constrained resources you have, but you just didn't have time to learn that the dog died. So there's a good chance she's going to end up in A&E because of that night medication.
Yeah. So there's a great bit of practice, I think, a couple of years ago from an ICB, I think it was in Sussex. They gathered together a large group of people who were on the musculoskeletal waiting list, brought them together for a day with clinicians of various kinds, I think voluntary sector organizations, various other people, and talked to them about a variety of options. And at the end of the day, quite a high proportion, I think 40% or so of these people maybe had said they didn't really want to be on the waiting list anymore, that they could treat themselves, that they were going to have some alternative way of dealing with it, or that actually they understood that the operation that they might ultimately have had wasn't really going to do them a great deal of good. So we kind of know that if we can engage patients in this way, they can see a range of alternatives. We give them a bit of time. The consequence is not, as I think we tend to assume, that I think there's an assumption often in the health service, which is the more time you give people, the more you'll end up having to do for them. Whereas actually your argument is, no, if you give people more time, you probably end up having to do slightly less, or slightly less in a medical context.
Not slightly less, a great deal less.
A great deal, right?
Yeah, not slightly less, a great deal. And there's a lot of evidence to demonstrate that. What we focus on in the podcast, just to try and simplify, is 5 levels of disabling quality. And level 1 is doctor knows best. And that's what most patients have been taught to believe their entire lives. Level 2 is, if you look at this variation, even within practices, there must most often be more than one reasonable thing to do. At that point, people say, well, how do you narrow down? And we say, no, don't narrow down. You have to expand the menu first. You have to recognize how complex it is to understand what brought a patient to the GP surgery, complaining of hip pain or back pain or insomnia, because those generalized symptoms are very often related to emotional or social needs that are much more embarrassing to talk about if the patient recognizes that that's the case, and often they don't. Much more embarrassing to talk about the fact that your banister broke and you're much more lonely than you've ever been before because your daughter moved away and there's no one able to fix your banister. So you come in and say your hip pain is worse. you get the referral to the.
Yeah.
There's a true story.
Yeah.
There's a true story that we learned in our first iteration of these 8 essential capabilities that we could talk about if you like. But in that case, the patient came back to the GP and said, I wish I'd known this was going to be so difficult, the reanimation. I just couldn't get down the stairs comfortably because my banister broke. So how often do we replace this rather than repair banisters? Because there isn't time to understand what is going on.
So
good GPs know
yes.
that you ask the question, tell me your story, and you don't interrupt.
Yeah.
And when they do stop, you hope you have the time to say, oh, that doesn't sound very good. Tell me more about what you're going through. And what you're doing there is trying to understand whether that insomnia is due to depression, which a lot of people can jump to because it's a early morning awakening is a cardinal sign, or it's because of domestic violence or any other thing that needs a different kind of treatment.
Let's think about your ideas in the context of 2 or 3 kind of topical questions for the NHS. So one is around the notion of neighbourhood health. We've argued strongly at the Confed here that neighbourhood health has to be about a different model of care and a different relationship with communities. And we find that argument, which goes to the idea of a more holistic offer, recognizing that often the issue that people have is to do with housing or debt or all sorts of things, not necessarily needing a medical solution. And the notion of engaging more deeply with communities to try to understand what assets are available in those communities and what are the kind of assets we need to build. I often tell the story of being in Birmingham, talking to the neighbourhood team there, and I said to them, what was the one resource you'd like more of in terms of referral? And they said befriending. So not a medical service, not really a statutory service, but provided by the voluntary sector. So I don't know if you've got involved in this conversation about neighbourhood health, but what would you say is essential if we're going to capture the idea that is contained within neighbourhood health, which is that it's a much more kind of holistic, proactive, empowering model of care?
Let me go back to my personal story for just a moment before I address your question about what we've seen in the UK in our work. When I was a student in training in Massachusetts General Hospital, it was viewed as one of the most technically, scientifically sophisticated institutions in the world. And leadership there, the general director and the chief of medicine, decided that they were not going to compete to do the first heart transplant. This was in the early 1960s. When that transplant was done for the first time in South Africa, not to very much benefit for the patient, it was the same year, 1967, that the MGH opened a community-oriented primary care center in the Irish immigrant community just north of Palisade. And my mentors there recognized the importance of understanding cultural context and cultural intelligence, as well as emotional and social intelligence in addressing both decision quality at the micro level and at the macro level. What does this person need? Is it medical or is it emotional? Is it social support? And at the macro level, how do we engage the schools so that we're dealing with one of the segments, the chapter 2, parents and children? How do we engage others in the community? So, I am incredibly grateful for having, arrived at Harvard when they were announcing a new PhD program in public policy. And when the MGH was announcing a new training program that, had me learning not only from the best consultants, some of the best consultants in the country, but also from advanced practice nurses who led our outpatient rounds 4 days a week. And on Friday, outpatient rounds were led by a social worker.
Mm.
So there's that background.
Yeah.
And working here with the vanguards, I recognized how unusual my experience. I started writing the first textbook of primary care at a time when I was still training, and it was published when I was attending in the intensive treatment unit. So being able to talk to people in the acute trusts in Middlesbrough, for instance, about decision quality in A&E, and in primary care, is something that has opened doors to helping them see that the people they're accountable to don't understand complexity of decision making at the front lines. They're focused on system functions of primary care, access, most importantly, because a problem with access is visible to patients who are voters. They're not aware of the complexity of medical diagnosis and treatment, psychological diagnosis and treatment. We've already talked about how those are intertwined. Support of patients from all backgrounds and all phases of illness. Treatment decisions, explaining prognosis. All of those things are really very complex. And they all involve learning from variation in order to avoid underuse in the neighborhood, making prevention impossible often, or overuse in the neighborhood, causing clinical cascades that lead right through A&E into the hospital and ITUs.
So it's so fantastic talking to you. I could talk to you for hours, but I'm going to just ask two further questions. The first is, in terms of general practice, in terms of GPs, in terms of those people who want to argue about the importance of GPs and investing in primary care, but particularly in GPs, I think you've got one thing to say which is kind of comforting with that argument, but one thing that's a bit more challenging. So I think the comforting thing is, I think you recognise the importance of continuity of care, although we need to be clear about what it is: continuity of information, continuity of person, continuity of care, but that's important. But on the other hand, it doesn't actually have to be a GP, does it, who has the GP needs to be there to be called in, but it doesn't have to be the GP who has the conversation.
And ideally, they're not even called in.
Right.
But let me get back to your question about what we're talking about. I think is essential for people building neighborhood care systems. The opportunity to make right decisions in neighborhoods with the left shift in the community is the opportunity to make the NHS sustainable. Yeah. We stopped at level 3, broadened the menu of decision quality. Level 4 is get rid of all the biases, including the biases that come from uninformed commissioning decisions, because they don't have that feedback loop, which is the aggregate of the needs and wants revealed by high-quality decisions. Yeah. So you get rid of all of those biases, and as you know, that's our interview with Dave Paslow, who knows a lot about it as former chair of the RDP and NICE. And then the 5th brings you to the ultimate, the pinnacle of decision quality, and that's raising the voice, getting power to the patient. But you have to get them away from level 1.
Away from assuming a single medical solution.
No, the sense that the doctor knows best.
Right, yeah.
Yeah, right.
Yeah.
That you're a machine and this is a mechanical problem. You're much more complex than a machine. So you need to find ways to engage patients. You need to find ways to help clinicians engage patients. And that's why we talk so much about listening capacity. The goal of any service provider in health and social care should be to make people feel known and cared for by someone they can trust.
Right. So continuity does matter.
It really does.
But it doesn't have to be a clinician who provides that continuity. Or does it have to be a doctor?
Based on my experience trying to I was chief of general medicine for nearly 30 years at the MGH. I tried to reform, improve healthcare in 5 different ways. They all worked, but marginally. When I came to Dartmouth, one condition of my movie was to start from scratch with a new model of primary care. I'd spent a lot of time with Chris Turnbull, who was a co-producer of the podcast and a co-author of Patient Preferences Matter. And starting from scratch gives you lots of advantages that most GP services don't have. But if you follow his advice, you can actually do. And starting from scratch what I said to the chief executive of the time was that you're self-insured, you're a clinician, you understand healthcare. Self-insured means the insurance company is just providing administrative services. It also means you're the policymaker. If you want to double the proportion that's spent upstream, if you want to create that kind of left shift, no one can stop you from doing it. And if you want to capitate it, so you have more like GP, British GP incentives, you can do that as well. The only condition you should hold these colleagues that I introduced them to, you should hold them to in the operating model, is that people will spend less than 50% of time they currently spend one-on-one with a doctor or nurse. And they will be delighted more than ever before by the care they receive. And that model, instead of having 4 GPs, so the Dartmouth employees, had 2. Right? Instead of 2 nurses, had 2. Instead of 4 receptionists, there were no receptionists. There was a behavioral coach and 10 general health coaches. Recruited from the community, only half we had experience in primary care. They were recruited for their relational skills, their ability to affirmatively listen. After a year, the Net Promoter Score was 93.
Yeah. That's such a powerful lesson as we think about our model of neighbourhood health there out. Final question. There's a lot of emphasis on digital, AI. One of the big announcements at Labour conference that we had recently was more outpatient appointments to be undertaken virtually. We can see the upsides of all of this. Do you, what in terms of the upsides and the downsides, given the emphasis you have on human relationships and human decisions, how do you feel about the idea that more and more of these conversations will be taking place virtually or potentially algorithmically?
Yeah. I'm currently proofing the Chapter 1 of Primary Care Medicine, which I'd just recently revised. And the major revisions were about corporatization of primary care in the United States. And you don't want to go anywhere near that, but also the role of AI. And I only had a few paragraphs to deal with this. And what I ended up stressing was the role of human values in medical decision-making. And I cited a number of papers that address that head-on, both from here, from institutions like Oxford and others, Imperial, and from the U.S. And I think that as long as people are paying attention to verifying the value of AI interventions that should be paid to diagnostic interventions and therapeutic interventions and hold AI to the same standard, we'll be okay. Commercial interests won't do that. It's one of the reasons why I think the NHS has the opportunity to show the world what smart, intelligent regulation of these potentially wonderful innovations could do if somebody is looking out for the welfare of the patient as first priority.
Yeah, I mean, what worries me is this early evidence that AI seems to make people less intelligent, actually, the use of AI. And I worry that the emotional intelligence, which you emphasize so much in terms of the decision point, that if we are over-reliant on algorithms, if we are over-reliant on systems that almost distance the patient from the person who's advising, then we will think it's making us more efficient, and it won't be.
No, it will never be able to be more than an advisor, in my view. Can't be the decider. And it's because I don't see it being able to deal with the variation in utilities, risk attitudes, discount rates that we talked about, to use the technical terms. And I don't see it being able to bring the emotional, social, and cultural intelligence to decision points that is needed. So not a decider, an advisor. And the other, one of the papers I paraphrase quickly in this chapter, used the kind of decision theory that I was schooled on at Kennedy School in order to test AI. And what it did is it gave it all the same information, but gave that information to different stakeholders, to a child's parents. It was a question of early short stature?
Yeah.
And do you treat it? So if you give the same information and you're allegedly posing a question to the child's parents, you get one response. If you're posing it to the clinician, you get a very different response.
Right.
And if you're posing it to the insurer, you get an even different response. It's a very clever way to highlight the risk of losing sight of human values in AI.
Well, Al, it's been an honour talking to you. This episode of Health on the Line is just an extended trailer for your wonderful podcast series, The Choice, Securing the NHS for the Next 75 Years. So, folks, if you've enjoyed this conversation, immediately go and start listening to that podcast. As I say, particularly relevant, I think, now as we start to think about what is at the core of the neighbourhood health model. Al, thanks so much for joining us.
Thank you, Matthew. Very kind of you. Thank you.
You've been listening to Health on the Line, produced by HealthComms Plus. HealthComms Plus is a highly effective, innovative and creative communications agency brought to you by the NHS Confederation. We offer a creative, professional and cost-effective service for NHS and public sector organisations across the UK. Any profit we make is reinvested in the support we provide to NHS organisations and wider health and care systems.